What's up, Ninja Nerds? In this video today, we're going to be talking about acute leukemias. This is a part of our clinical medicine section. If you guys like these videos, it makes sense to you, please support us. You can do that in a couple different ways, and it really does go a long way. You can hit the like button, you can comment down in the comment section, and you can subscribe. Also, we have a website. If you guys go down in the description box below, click on that link, it'll take you there. On our website, we have great notes, illustrations, quiz questions, all those things that will help you that go beyond what we talk about sometimes on this lecture. And I think it'd be good spaced repetition to help you out for your exams. Go check it out. All right, let's dig into the pathophys. All right, so let's begin our discussion on the pathophysiology. So when we talk about acute leukemias, this is basically two different types. One is acute myeloid leukemia, AML, and the other one is acute lymphoblastic leukemia, or ALL. Now, when we talk about these are really disorders of hematopoiesis, so we have to define what that is. So hematopoiesis is basically, imagine here's your bone marrow, right? You know the site of white blood cell production, red blood cell production, platelet production, all of that's the red bone marrow. So we can define hematopoiesis as the site of blood cell production. And that occurs where? In the red bone marrow. So for example, let's say that I have here a bone. In this bone, right, we'll have some red bone marrow. That red bone marrow is the site of where we're going to make all our different types of cells that circulate throughout the blood. The white blood cells, this could be the granulocytes and the agranulocytes. This could be your red blood cells, and this could be your platelets. Question you may have is, how do I take this bone marrow and make all these different types of cells? Well, that goes back to your physiology. So you have to remember, inside of the red bone marrow, there's a stem cell. This stem cell is called the hemocytoblast. So the hemocytoblast is basically like a pluripotent stem cell, which can make all different types of cells. That's what makes it cool. I can make red cells, white cells, platelets, all these different types. What's really cool is that this guy can differentiate. So imagine he proliferates himself, and then he differentiates to become more specialized. So he's no longer going to be this kind of cell. He's going to become these two different types of cells. This one over here is called a lymphoid stem cell. Let's write that out. And this one over here is going to be the myeloid stem cell. We have these two cells that are different from that pluripotent stem cell. What's really important at this point is this is where we kind of diverge. So at this point, if there's an abnormality in this process, it's going to lead to maybe the ALL. If there's an abnormality in this process, it can lead to AML. We just have to figure out where exactly in this process. Let's come down this arm first. Myeloid stem cells, what can happen is they can actually further differentiate. And what happens is they can differentiate into what's called a myeloblast. And myeloblasts are important because myeloblasts will then further kind of like change their neutrophil, become more segmented, and they can become granulocytic white blood cells. So again, which one's this one called? Just so I can be very, very specific, myeloid stem cell to a myeloblast. Now, the thing here is whenever I have a myeloblast, this is going to make my granulocytes. And there's different types of granulocytes here, right? So we have neutrophils, we have eosinophils, and here we have basophils. These are all really important because they are going to be derived from that myeloblast. As a whole, we call these a very specific type of white blood cell. You know what we call this one? We call these granulocytic white blood cells, or granulocytes. So here's what's important. A myeloblast can turn into all of these different types of white blood cells. The next component here is that sometimes this myeloid stem cell can also differentiate into some other different types of cell lines. I'm not going to write them down, but it can become a, what? An erythroblast. An erythroblast can then further differentiate and become a red blood cell. So this could become a, what? A red blood cell. Or it could further differentiate from this myeloid stem cell and become a megakaryoblast, which then eventually becomes megakaryocytes and blows up into a million pieces and becomes platelets. And then lastly, this actual myeloid stem cell could also differentiate further and become a monoblast. And monoblast actually could go further and then turn into a monocyte. So this could become a monocyte. So this is your basic physiology when it comes to hematopoiesis. When we talk about this with acute myeloid leukemia, the problem exists here, that you have lots of myeloblasts. So really, this is what's happening. The bone marrow is producing tons and tons and tons of myeloblasts. So that's really where this disease comes into play. You have increasing amounts of myeloblasts. If you really want to define it, if I were to take the percentage of these cells and how much they occupy within the bone marrow, you have to have at least greater than or equal to 20% of these cells in the bone marrow. So I really need a lot of these things. That's a significant proportion to account for inside of the bone marrow. Now, with myeloblasts, the question is why am I making a lot of these myeloblasts? We'll get into that, but the myeloid stem cell can differentiate into a myeloblast. But what if I shut down the myeloblast further differentiating? It no longer turns into a neutrophil. It no longer turns into an eosinophil or a basophil, and sometimes this could even affect your monocytes as well. If that's the case, this builds up, and then all this guy does is he just keeps replicating onto himself. He keeps replicating and proliferating. And then what do? You get a substantial amount of myeloblasts. When that happens, guess what you have? You have acute myeloid leukemia. Now, AML is interesting. With AML, there is 8 subtypes. And I don't want to go through all of them because it's not as high yield as when we get into ALL. But we kind of say these are M0 to M7. And the most important subtype that you actually do have to remember, because it's pertinent, because it changes the whole prognosis of the patient, it's a different treatment for the patient, is APL. And this is the M3 subtype. So the M3 subtype of AML is also referred to as acute promyelocytic leukemia. This is the only one that you have to remember as the subtypes. And the reason why is this one has a completely different treatment and prognosis. This can lead to DIC. That's worth knowing, right? Absolutely. Here's a question I think I had when I was learning this topic. How in the heck would I know if a myeloblast is building up inside of the bone marrow? Well, one of the things is some of these myeloblasts, they seep into the bloodstream. And if I got a blood smear, I may be able to find these things. But the best place is to take it out of the bone marrow. And when I look at these myeloblasts, they have special types of markers on them. And so what we would see is when you actually look at these under the microscope, you would see these things called hour rods. You see these like these little pink structures right here? These are called your hour rods. And these are an identifier. So when you see these on a bone marrow biopsy, or if you get lucky and you see it on a peripheral blood smear, that's very specific for AML. Another thing, you see all these like maroon dots? All these maroon dots are a special type of like enzyme that's present really in myeloblasts and not in lymphoblasts. You know what that's called? It's called myeloperoxidase, or MPO we commonly abbreviate it. So if a patient has the presence of hour rods on peripheral blood smear or their biopsy, if they have the presence of this enzyme when we do what's called flow cytometry, that's really suggestive of AML. There's another thing, I'll talk about it just because we're going to talk about it over here and I don't want you to think that they don't exist, but you see these like little blue proteins? These little blue proteins are called cluster differentiation proteins, and they differentiate different types of white blood cells. There's a bunch of them, and I don't think they're super worth the squeeze, but I just want you to know that they do exist, and this is CD13 and 33. If these do tend to be positive, it's not going to be super specific for AML as compared to the MPO and hour rods, but it is worth knowing. These are identifiers of the myeloblast. So I got a bone marrow biopsy, I see the myeloblast, I see this, I test for these things, oh baby, that's a myeloblast. And then all the downstream consequences that can occur in this become more easy to understand. All right, we now move into the acute lymphoblastic leukemia. Lymphoid stem cell, this one turned into a myeloid, and look at all the things that could go from there. The lymphoid stem cell is not as much. It really just becomes a lymphoblast. So here we're gonna have a lymphoblast. Then from the lymphoblast, it then further differentiates. And when it further differentiates, it differentiates into what's called T cells and into B cells. Now, technically we call these T lymphocytes and we call these B lymphocytes. But for right now, I'm just gonna write T cells and B cells. Okay, so here's the pathway now. So we saw from the myeloid, you can make red cells, platelets, and all these different types of granulocytic white blood cells and monocytes. From lymphoid stem cells, you really only make T cells and B cells. And if you want to go a little extra mile, it makes natural killer cells. Don't go too crazy. But the problem in this disease is the same thing. It's right here, the lymphoblast. It's not fully differentiating into T cells and B cells. And all it does is, it just keeps replicating on itself. And as it replicates on itself, you build these puppies up inside of the bone marrow. If they build up in the bone marrow to the point where there's so many lymphoblasts. How many I put there? 3? We'll do 3 here again. So many lymphoblasts. What's the percentage have to be? Greater than or equal to 20%, baby. That's a lot. So at that point, that's now causing acute lymphoblastic leukemia. The next thing I need you to know is there's 8 subtypes for AML. What about the subtypes for ALL? You know, it's pretty cool. So for this one, it's only 2 specific ones that I really want you guys to know about. One is going to be T-cell ALL. All right, so watch this. I'm actually going to bifurcate this puppy. So we're going to bifurcate this one. And when we bifurcate this, we're going to say if I have lots of these, let's say T lymphoblasts, lots of the T lymphoblasts, and I have too many of them, that can make what's called T-cell ALL, T-cell predominant acute lymphoblastic leukemia. All right, way less common. All right, way less common. Only accounts for maybe 20%, maybe 20% of ALL. The more predominant one is when these lymphoblasts, the ones that are made up here, is if they're B lymphoblasts. This determines a patient having B-cell ALL. And this one is much more common, 80%. So if I tell you what's the big subtype to remember for AML, the most important one is M3, or which one? It's M3 or the APL. If I tell you which one to remember for ALL, it's B-ALL. Here's the question. When I have to identify the difference between a T lymphoblast and a B lymphoblast, it's different. So for example, I'll talk about this later. When we talked about APL, it really differs. They still have ALROS, they still have MPO, they still have these CD proteins. What really difference between APL and all the other of the 8 subtypes is that APL involves promyelocytes, which we'll talk about when we get down here. For this one, they're both lymphoblasts, so their morphology is not really different of their structure or the type of cell and their stage that they are during the differentiation. What really helps to differentiate these is when we look inside the cell. What are these like little orange dots? These are called TDT. So it's a terminal deoxynucleotide transferase. You don't need to know that whole thing, just know TDT. If they have the presence of TDT on the inside of the cell, that suggests ALL, all right? That's what's really important to remember. This suggests ALL, all right? Whereas, if I said MPO, that one suggests AML, all right? That's the big difference. Now, cluster differentiation proteins were not as high yield for the myeloblast, but they're super high yield for the lymphoblast. So look here, you see these? On the T, they're CD2 to CD8. So CD2, CD3, CD4, CD5, you get the point. Anywhere from CD2 to CD8 suggests a T lymphoblast. But if I have cluster differentiation CD10, CD19, CD20, these are suggestive of B lymphoblasts. That's what I need you to remember. So the identifiers for T lymphoblasts, let's actually make sure this is very clean here, CD2 to 8, that suggests the T ALL, CD2 to 8. And if I say CD10, 19, 20, you would say B lymphoblasts. And this is your B cell ALL. All right. So we have our identifiers, TDT, ALL, MPO, AML, CD2 to 8, TALL, CD10, 19, 20, BALL. If I said which one is the most important AML subtype because it's promyelocytes, you'd say APL. All right, I think we got that. Last thing I wanted to talk about is that when you get to a blast, technically when we talk about how leukophoresis, making white blood cells, occurs, you always start off with a blast. Then it becomes a promyelocyte. Then it becomes a myelocyte. Then it becomes a band cell. And then it eventually forms a functional granulocyte. I'm just using this as an example, right? For lymphoid, it would be a lymphoblast, a prolymphocyte, then a lymphocyte, T or B. Whenever we go through these stages if it's in the earlier portions of the differentiation stage. Here, that is acute. These are the cells that are more likely to be involved. The blasts. So this is what's really important to remember. This involves the blasts. Later, in these parts where the nuclei are starting to segment, they're starting to become more specific and more functional. That's chronic. So it's not going to be as many of the blasts now. You're going to have more of the close to functional, but not quite there. So we're going to say a little bit, we're going to say less mature white blood cells. It's because they're not really blasts. You're going to have a lot of these, but they're going to be at the later stages where they're just not close yet to being mature, but they're definitely a little bit more functional than these acute ones. The problem with this is that blast makes the progression of the disease rapid, all right? So this is rapid progression. Whereas chronic it's a little bit slower. Because these are a little bit more functional as compared to these, they're a little bit smaller, you're not going to have as much of that devastating effect. And so because of this, this will be a gradual progression. I'm killing it, right? Mm-hmm. All right. So at this point, we've talked about a lot the pathophys of acute leukemias. What I need to now say is, okay, what in the world is causing these lymphoblasts to build up, or they don't differentiate, but they just keep proliferating? What causes the myeloblasts to not differentiate, but just continue to proliferate? And then once we do that, we can say, what's the problem? Why is having so many of these myeloblasts or lymphoblasts in the bone marrow, out in the blood, or in the tissues a problem? So with this, we talk briefly, and I mean briefly, about what we just said. When you go through from a myeloid stem cell to a myeloblast, you go to what's called a promyelocyte. Remember I told you that most of the time, if you have a myeloblast and you build these up, that's your AML. That's usually M0 to M7. So really, whenever this builds up significantly, that's going to be what's really triggering a lot of this stage for, M0 to M7, except for, so M0 to M7, AML, what's the only exception? Except M3. I just don't want to write M0, 1, 2, and then all the rest of them. So that's the big thing there. But if I have lots of these, oh man, oh daddy, this makes the M3 AML. And that is defined as APL. So at these stages, what's happening is you can have lots of blasts that can make these types of problems for AML. Or you can have lots of promyelocytes. That'll make a lot of the problems for the M3 AML. Problem is they get stuck in these stages and they never further differentiate. The question is why? Why does it get stuck in this proliferative stage but not in the differentiation stage? And there's usually, for acute myeloid, it's genetic. So it comes down to chromosomal translocations. And so one of them that's relatively important to remember is for APL. That's why I kept stressing that's the really important subtype to remember out of the M0 to M7. For APL, we care about a specific type of chromosomal translocation, and it's called the 15-17 translocation. What happens is, on chromosome 15, you have a PML gene. On chromosome 17, you have a RAR alpha gene. This is a retinoic acid receptor. What happens is you end up swapping some of that genetic data and you end up making a fusion gene. So now I have a fusion gene, which here's the PML and here's the RAR alpha. What do I make? I make the promyelocyte retinoic acid receptor alpha gene. That's what it's called. So PML RAR alpha gene. When you got a lot of this gene, dude, oh boy. It causes the promyelocytes to rapidly divide, but never differentiate. That's the concept here. And so the big thing to remember for why I talked about acute myeloid leukemia, the specific subtype APL or M3, is because this one is defined as a 15-17 translocation. The other ones don't really have that. Now, with that being said, in patients who have what's called trisomy 21, which is known as Down syndrome, these patients have a higher risk of developing. So they have a higher risk of AML. Do you know how many times? 10 to 20 times. That's significant. If a patient has Down syndrome, they have a 10 to 20-fold risk of developing AML or ALL. That's pretty significant. So that's really important to remember as a potential trigger or a relative causative factor. But basically, these genetic abnormalities are basically shutting down the differentiation, but triggering proliferation. Now, other causes that I think are just important to quickly just check off is don't forget about chemoradiation. So chemoradiation can have that type of damaging effects and can definitely lead to mutations that are arising, and that can cause proliferation without differentiation. Other ones are going to be myeloproliferative disorders. So myeloproliferative disorders. We talked about this in another video. So this was your ones like polycythemia vera, essential thrombocythemia, chronic myeloid leukemia, and primary myelofibrosis. All of these carry that risk of converting into AML because as they proliferate, you bring about the opportunity for more mutations. And even if you wanted to, I could add in another one, but I'm not going to go too crazy on this one. It's called myelodysplastic syndrome. So this is a disease where you have dysplastic white blood cells. And you can have blasts that are starting to form, but there's less than 20% of them. Whenever it converts from less than 20 to greater than 20, or greater than or equal to 20, that's the definition of AML, all right? So that's the concept here. Now, for ALL, or acute lymphoblastic leukemia, you have blast, goes to a prolymphocyte, but it gets stuck right here. So it does not further differentiate. And so you don't go down this pathway. And so what ends up happening is you build up these blasts, right? And this is what leads to your ALL, which could be the B type or the T type. Now, when we talk about these are usually going to be really important genetic causes. So one of them is a sign of a good prognosis. And interestingly enough, we see this in children. So oftentimes it's really, I can't stress enough, really important to remember that ALL is a disease of little people. It's a pediatric type of cancer. AML is a disease of older individuals. CLL, CML are all diseases of older individuals. But ALL is a pediatric disease. So because of that, you're going to see this in younger patients. So you're going to see this as our pediatrics. There's a very small percentage of people that can have ALL that could be a bad prognosis, but we see this more in adults. And this could also be due to a genetic problem. What's the difference? For the good prognosis, it's usually due to a 12-21 translocation. Like the PML RAR alpha gene, I don't think it's as high yield, but you have an EVT6 gene that gets passed over to a RUNX1 gene. You're probably like, I don't know what that means. Don't worry about it. It's not that important to remember. But you get this EVT6 and you get this RUNX1 gene, and I'm going to write them down, but please, for the love of everything, and holy, please do not memorize this. I'm just trying to give you an idea that you get this gene, and this is the gene that's responsible. The same way the PML RAR alpha gene is there, this is the other gene that's going to kind of put the accelerator on proliferation, but not on differentiation. And that's what happens. It just gets stuck here and it just keeps proliferating. This is what we would see in younger patients. This is the one that I need you to remember. This one, not that common. But you can see this with a 9-22 translocation. You take a BCR gene, fuse it with an ABL1 gene. When you fuse that, you get something really bad. This is called the BCR ABL1. So this is going to be called the BCR ABL1 gene. And what this does is this accelerates your tyrosine kinase pathway. And the tyrosine kinase pathway is going to do the same thing that we've been talking about a million times. It's going to put the accelerator on proliferation, but a block on differentiation. And that's what's happening here. I already mentioned this before, but again, trisomy 21 is just a nice little quick reminder that patients with Down syndrome, what happens? They carry a significant risk. Anytime you have this, you increase your risk of ALL and AML by 10 to 20 times. That is the big thing to remember, okay? Other causes, again, chemoradiation is a potential trigger here. If you cause that chemotherapy or that radiation, it can cause damage to cells. And if you cause that, you can lead to mutations, obviously. And the last one is an infection, but it's a very specific one. It's called the HTLV infection. This one is only specific only for T cell ALL. Is it really important to remember it? Probably not as much, just because T cell ALL only accounts for about what, 20%? But at least consider that. All right, this is our causes. So at this point we've said, does the patient have AML? It's the myeloblasts. I got a lot of them in my bone marrow. There's 8 different subtypes. The most important one is APL. Or is it ALL? Lots of lymphoblasts, lots of them in the bone marrow. Is it B or T? I now know how to identify the differences between T and B, and how to know if it's a myeloblast. That's very, very specific on bone marrow and other special studies that we'll talk about in the diagnostic section. And then I even told you guys to remember what are the most important genetic causes that are happening, where we put the accelerator on proliferation, but the brakes on differentiation. For AML, the most important one is the 1517 translocation. For ALL, it's the 1221. Rare cases, 922. What's the disease where you have 3 chromosomes, which increase your risk by 10 to 20%? That's Down syndrome. That's the big things to take away from this. So now that we've done that, I want to talk about the havoc that these blasts, myelo or lymphoblasts, have on our body when they're in the bone marrow and proliferating, or when they're in the tissues depositing. Let's do that now. All right, so let's talk about the classic clinical findings that we see in acute leukemias. When it comes to leukemia, they have kind of a beautiful classic picture, I would say, that you should be thinking about. One of them is pancytopenia. The concept behind this is that regardless if it's AML or ALL, they both have a hypercellular bone marrow. For AML, their bone marrow is filled with myeloblasts, whereas if it's ALL, it's filled with lymphoblasts. Now, when you have all of these kind of building up in the bone marrow, they take up a lot of space. They're pretty honky cells, right? So they're chunky cells. And so with that being said, you're going to crowd out the bone marrow per se. And by crowding out that bone marrow, you make less space in the bone marrow that's needed for other cells to divide and to form, right? And so that's what usually starts to happen, is because of all of this, you crowd out. We're just going to use that in quotations per se. You crowd out the bone marrow. Now, when you crowd out the bone marrow and you make less space, what happens here is that you don't have enough space for other cells to develop, proliferate, and then form, such as our red cells, our platelets, and our white blood cells. And so because of that, we can't push other cells out of the bone marrow into the bloodstream. So we're not forming our red cells, we're not forming platelets, we're not forming our functional white blood cells. Now, what's it called whenever you have less red blood cells? So whenever there is a decrease in the number of red blood cells, and we measure this on our CBC via what? Hemoglobin. So technically, the hemoglobin is what's actually going to be low, right? If we're really being specific. When you look at a CBC, you'll see that there's less red blood cells, there's less hemoglobin, there's a lower hematocrit. That might be the way that you diagnose these patients as having a form of the pancytopenia, the anemia portion. How does anemia though, so this is how we would define anemia, right? So we would define this part as anemia. Anemia could be a laboratory diagnosis if the hemoglobin is less than 13 in a male or less than 12 in a female, but how would they come about symptomatically? So anemia can present symptomatically based upon the presence of fatigue, pallor, dyspnea. These are usually classic signs, but I'd say the most common one is fatigue and pallor. All right, so that's one thing. You get a CBC, shows a lower red cell line. They have symptomatic that could be anemia. The next component here is, what if the platelets are lower? So if you have less platelets. Now, less platelets is pretty straightforward. It's no specific kind of like parameter like hemoglobin. It's the platelets itself. So if they're low, this is called thrombocytopenia. And this is defined as less than 150,000 platelets. When you have less of these, the symptoms is that of what platelets do. So red cells are designed to deliver oxygen to the tissues. So the reason why you develop fatigue is because you have less oxygen delivered to the brain. You'll have generalized weakness because of less oxygen delivery to the muscles. You'll have pallor because of less oxygen delivery, which carries that reddish hue to the skin, particularly to the conjunctiva and as well as other tissue spaces. With platelets, they're supposed to help you to clot. And if you don't have them, you can't clot, so you will bleed. And so therefore the symptoms could be bleeding, and usually platelet-related bleeding or bruising is usually kind of a classic picture. So the bleeding is usually going to be things like gingival bleeding, epistaxis, menorrhagia, prolonged bleeding from like a cut. So those are things that suggest a platelet disorder related bleeding. The bruising is usually in very small little blots on the skin, like petechiae and purpura. All right? The next component here, this is the interesting thing. When you think about all these lymphoblasts or myeloblasts, they're white blood cells. They're just not mature. All right? So what could happen is, and this is what usually can get people, you crowd out the space, which leads to less space for functional white blood cells. And the most important one that we really care about here is our neutrophils. And so you can get less functional white blood cells. So you can have a decrease, and I'm going to be very specific. I'm going to say functional white blood cells. And this is defined as leukopenia, meaning you have a decreased number of white blood cells. What's an example, again, of the most important one? So the example here that I would want you guys to think about is neutropenia. All right, neutropenia, when you have a decreased number of neutrophils. Now, here's the problem. Leukocytes, all right, they are white blood cells. When you get a CBC and you see, oh, the red blood cells are lower, the hemoglobin, the hematocrit is lower, that's anemia. Oh, the platelets are lower because that's thrombocytopenia. The white cell count may not always be low. It's the amount of functional white blood cells that'll be low. Because what will happen is when you get the white blood cell count, you'll have the lymphoblast or the myeloblast plus some of these functional white blood cells. Your white blood cell count could be very high, it could be normal, it could even be low. It really depends, so it's a variable white blood cell count. What is important to know is when you look at the differential. So the white blood cell count could be pretty high, could be normal, could be low. But when you look at the differential, and that's the key, you're going to have less of these neutrophils, basophils, and eosinophils, but neutrophils is the most common. The reason why this is important is functional white blood cells are supposed to help you to kill bacteria and viruses and infections. And so now you can have frequent infections or fevers. This is where I want to talk about an example of why this is so important. When you have all these blasts that are taking up the space and you have less functional white blood cells that are circulating throughout the bloodstream, especially neutrophils, and how we truly define this is whenever the absolute neutrophil count is less than 500 plus a fever, this is an oncologic emergency. So if a patient has AML or ALL, their neutrophil count, when you calculate their absolute neutrophil count, if it's less than 500 and they have a fever, this could be a sign of a really scary disease. And this could indicate something called neutropenic fever. And it's actually worth remembering this. So neutropenic fever. This is the patient that if you have a patient with an absolute neutrophil count of less than 500 and a fever, you don't know where that could be coming from. And you have to assume that they have a really bad infection going on. Could be pneumonia, could be sepsis, could be urinary tract infection. You need to get blood cultures, urine cultures, all different types of cultures, start them on antibiotics once you get those cultures, and try to suss out what's going on. These patients are super high risk and they can die. All right? So with that being said, patient comes in, they present with fatigue, pallor. Their CBC suggests that. That's the anemia component. They come in with bruising, bleeding. Their CBC suggests thrombocytopenia. That suggests the part of this. They come in with variable white blood cell counts, but when you look at the differential, there's less neutrophils. And they're having fevers or they're having frequent infections. That accounts for that component of pancytopenia. You can see this in either of these. Bone pain, you're not going to see as much in AML, and it's going to be more common in ALL. So here's what I want you to remember. I'm going to first off starting by saying that this is less common, this is more common. So more common for ALL, less common for AML. Either way, the same concept exists that we talked about here before. In AML, you're getting a boatload of these myeloblasts. In ALL, you're getting a boatload of lymphoblasts. And these things are honking big, man. They're huge. So because of that, they're taking up a lot of space. And not only does that space factor account for less production of other cell lines, it also starts expanding very undesirable tissue who doesn't really want to expand. It has to start to, do that. So then what happens is you start experiencing a little bit of bone marrow expansion. So what occurs here? You experience some bone marrow expansion. All right, and that's just because of all these cells taking up all that space in the bone marrow. This starts to really occur. When you get a lot of this bone marrow expansion, it occurs in specific types of tissues, usually long bones. What are the most common bones to be affected here? Well, the pelvis is going to be one, so the whole structure of the pelvis, the femur, and the tibia. These are going to be some pretty common ones. So think about any of the bones that make up the pelvis, think about the femur, and think about the tibia. These are all weight-bearing bones. If you have bone marrow expansion and it starts to involve these bones, what would be the symptomatology? These are designed to hold weight, bro. What's going to be the big symptom? The big symptoms from this is a patient will refuse to put weight, to bear weight, or they'll start limping because of the pain to kind of help with that process. So it could lead to a limp or a refusal to bear weight on that limb. So watch out for a patient coming in with pancytopenia and symptomatology of that, and bone pain with symptomatology of that. Should make you think of acute leukemia. But if you want to really be specific for the vignettes, it's going to be a little bit more common having bone pain with ALL, not as much with AML. That comes to the last type of classic presentation for these. Whenever you have AML, and it's a very specific subtype. Remember I told you there was 8 subtypes, M0 to M7? M3 is the most important one. I'm only going to quickly add this here, that you can have M4, M5 AML, which is called acute monocytic leukemia. So this is where that monoblast line is actually affected, believe it or not. And this one, the monoblasts actually come out here, and you get a lot of these puppies here. They get pushed into the circulation, out of the bone marrow, into the circulation. And from here, these cells go and deposit into the mucous membranes, as well as to the cutaneous tissue. When they do that, they cause some interesting process to occur in the gingiva. It can actually lead to a process here called gingival hyperplasia. And with that being said, not only can that happen, but it can also cause these raised bumps, raised like red, purplish bumps to appear on the skin. And this can cause an uncomfortable site as well, which we refer to as leukemia cutis. So whenever you have this one, you should definitely be thinking about AML. It looks a little bit like this. If a patient comes in and they have mucocutaneous findings and pancytopenia, which one are you leaning more to? AML. If I say a patient has pancytopenia and the bone pain, refusal to bear weight, or they're limping because of those bones being affected, you would say more likely ALL. How do we really iron out other complications or presentations of these two types of leukemia? Let's do that now. When we talk about these, ALL, acute lymphoblastic leukemia, in a perfect world, you may have a patient who comes in and they present with pancytopenia and maybe just some bone pain, you make that diagnosis. But oftentimes, patients come in a lot sicker. And it's important to be able to realize these presentations and to consider them, because they may come in with some kind of like non-specific stuff and it leads you to the diagnosis of ALL. What are those things? One of them is lymphadenopathy. I like to think about this easily. So lymphocytes love to deposit into lymphatic tissue. So whether that's nodal tissue, like lymph nodes, or extra nodal tissue, such as like liver, spleen, other different areas of the body, it's very common for lymphocytes to deposit into these tissues. So lymphoblastic leukemia is going to involve more organ involvement, whereas acute myeloid leukemia is going to kind of really reside within the bloodstream. That's where it's really going to do its kind of problems. And I think that's really important to remember, and it may help you to suss out these two types of disorders and their complication presentation. So lymphadenopathy, you get a lot of these myeloblasts, right? I'm sorry, lymphoblasts. you're pumping these things out of the bone marrow into the bloodstream. When these lymphoblasts get into the bloodstream, they go and deposit into the lymph node. Now you have these lymphoblasts depositing here, and they're going to cause enlargement of the lymph node. That's called lymphadenopathy. How would that present? Usually, it's going to be painless enlargement of lymph nodes. And what's the most common ones to be affected? Well, it could be the cervical lymph nodes, right? These are definitely common. The axillary lymph nodes are very common. The supraclavicular, the inguinal lymph nodes, and sometimes it can even get into the mediastinum. But I'd say the big thing about this one is it's kind of diffuse. It can hit a lot of different lymphatic tissue. Cervical, axillary, inguinal, supraclavicular, mediastinal. That's one way that we can think about this. Here's another thing. This chunk of lymphocyte, the lymphoblast, they get deposited in here. They also pump out cytokines. And so when they pump out cytokines, they pump out things like interleukin-1 and tumor necrotic factor alpha, which trigger the hypothalamus and cause fever, chills, things that kind of like are periodic. And sometimes we can call this B symptoms. So if a patient comes in with fevers, chills, fatigue, malaise, and on top of that, lymphadenopathy, painless lymphadenopathy, you think about lymphoma, consider ALL. All right? All right, the next one is hepatosplenomegaly. Same concept here. Your bone marrow is pumping out these lymphoblasts into the bloodstream. And these lymphoblasts, when they're getting pumped out into the bloodstream, just like they're getting pumped out here, they can go and they can deposit into the liver and they can deposit into the spleen. When they do that and they deposit into these kinds of organs, they're going to cause the organs to get larger. And this is going to lead to hepatosplenomegaly. Hepatosplenomegaly, one of the biggest things to remember is that your right side is going to be occupied, right upper quadrant, liver, left upper quadrant, spleen. It's going to push everything in the middle. What's right here in the epigastrium? The stomach. So the stomach is commonly compressed. So you get stomach compression. What's the stomach supposed to do? Don't you dare say, oh, it breaks down my food, bro. It does, yes. But it's supposed to accept food from the esophagus. If I compress the stomach, I make it smaller. Whenever food and fluids come into it, it stretches, and it's going to stretch a lot quicker, and it's going to reach that point where you're going to be fuller. It's kind of like acting like you have a bariatric surgery, essentially, like you did like a lap band or you did a vertical sleeve gastrectomy. It's the same concept. I wish I had that sometimes. But this scenario is going to cause early satiety. You're going to feel full. Again, I wish I knew what that felt like. Sometimes I eat like pizza over the sink like a rat, but hey, anyway, let's keep going. So we have hepatosplenomegaly. When these patients have these big enlarged livers or big enlarged spleens, sometimes it can be palpable. But the biggest presentation is early satiety or abdominal fullness. If you actually happen to get images of these, it would look a little bit like this. Okay, so we've seen now if a patient comes in with lymphadenopathy, they come in with hepatosplenomegaly, pancytopenia, bone pain, you're thinking ALL. Let's add another thing. Now, lymphadenopathy, hepatosplenomegaly, these can all be seen in any type of ALL. B cell ALL, T cell ALL. Which one's more common? B. So this last thing you only see in T cell ALL. So let's add that here. This is only, son of a gun, this is only in T cell ALL, only in T-A-L-L. And let's actually box this so that you guys remember. This is the only thing that you'll only see in this one, and you won't see in B cell ALL. And it should make sense. Bone marrow's pumping out what? Lymphoblasts. How do you identify it's a T lymphoblast versus a B lymphoblast? It's got the TDT, but it's got CD2 to CD8 for T, CD10, 19, 20 for B cell ALL. Just a little, seeing if you guys remember. From here, these T lymphoblasts, they go and they deposit into the thymus. This right here, this is your thymus. So now, you're gonna get thymic enlargement, bro. When that thing get big, it has mass effect. So then it's gonna lead to a mass effect. All right, that mass effect it means that it's going to push on structures nearby. Let's pretend, where's my green marker? Here it is. Let's pretend the thymus gets bigger and it enlarges and compresses this little brown tube. What's that brown tube that I'm smashing on? The esophagus. So if I compress the esophagus, all right, so if I hit the esophagus, what would that look like? That would cause dysphagia, difficulty swallowing, right? What if I compress this other guy? So now let's get a little green goob going here, branching out into this guy. What's this? The trachea. So now I'm compressing the trachea. What's that going to look like? Well, it's going to decrease airflow. That could lead to dyspnea, and in worst cases, it may even cause stridor, which is that really loud sound that you hear during inspiration. So they can be short of breath, or when they take a deep breath in, it sounds like they're really trying to squeeze air through a tiny little hole because the thymus is compressing on it. Here's the scary one though. The scariest part of the mass effect is if you compress the SVC. So if you compress the SVC, so now imagine here that this guy goes over here and it starts compressing on the SVC. Are you going to be able to get good venous return into the right atrium now? No, blood's gonna back up from the superior vena cava into the brachiocephalic, into your internal jugulars, into your subclavians. What's gonna happen? Oh, these patients can get real sick. So they can have, if it backs up the IJ, so let's say it backs up, so it'll cause back up into the internal jugular vein. So the internal jugular vein, that's gonna cause face and neck swelling. If it backs up via the subclavian veins, that's going to cause chest and arm swelling, right? Because you're going to be causing blood to back up, and that's going to cause the kind of enlargement of the veins. And on top of that, it's going to enlarge the soft tissue. So they'll look like they have a big swollen face, big swollen neck, swollen chest and arms. And it even gives a bluish, kind of like a light tinge of bluish discoloration to it. This is usually, again, what we would see here. So it's going to cause compression. So you're going to compress this. So you're going to squeeze on the internal jugular vein, squeeze on the subclavian vein, and you're going to get all this swelling. Now, here's what's really important. This can actually become an emergency. If in SVC syndrome, you get so much backflow. So if you get backflow of internal jugular vein, this can lead to impeded venous drainage from the brain. You know, the brain has the sinuses, which eventually drain into the sigmoid and then the internal jugular vein. Well, if you got a compression of the superior vena cava and it's already backing up, that's going to cause poor venous drainage because your blood's supposed to go from high to low pressure. But now you have the outflow, which is what's going to come out of the brain into the internal jugular vein. It's high. That's going to cause blood to back up. Intracranial pressure can go up. So this could lead to an increased intracranial pressure. Oh no, that's not good. The second thing is it could back up the internal jugular vein, and what happens is it kind of flows into these collaterals near the larynx. Those get enlarged, and the larynx can get edematous. If your larynx gets edematous, dude, you can't get airflow into your airway. That's terrifying. So sometimes it can even cause laryngeal edema. In these scenarios, this is emergency, bro. This can cause respiratory distress. This can cause them to herniate. In those scenarios, you got to get these patients and get a stent in that vessel and open it back up. Sometimes it's not common, but if you compress the superior vena cava enough that you can't get blood into the right atrium, you could even cause hypotension. But you see it more because it actually starts to really compress the heart like a tamponade effect. But that's not as common. I worry about these two big ones here. All right. So we see this as being a pretty big concern here, right? With T-cell ALL. Well, is there anything else? Yeah. So I had a patient when I was in the neuroscience ICU, young patient, was diagnosed with ALL, and she ended up having signs of meningeal leukemia. Because what happens is, this disease sometimes, man, it can be so rapid and so aggressive that they can pump out these lymphoblasts. And these lymphoblasts, they have sanctuary sites. The testes, it's a rare finding, but it can go to the testes. A higher likelihood of a sanctuary site is it can go to the meninges and it can deposit. So here, I'm gonna show these like little black dots here. This is the leukemic cells depositing into the meninges. They'll create like a meningeal reaction now. So it's gonna get like inflamed. So if you have an inflamed meninges now, that's gonna be called meningitis. They can get symptoms of meningitis, dude. It's just terrible. So what's that gonna be? Well, the biggest symptoms is headache, right? That's one thing, because when you involve the meninges, you affect the trigeminal nerve. You can also cause nausea and vomiting. You can also, the meninges spread down into the neck, so you can also get neck pain or nuchal rigidity. We'll put EG, nuchal rigidity. And you can even involve the cranial nerves. So you know cranial nerves 3, 4, 6, and even the second nerve can actually be affected. And so you can even get cranial neuropathies, cranial nerve palsies. The most common is going to be cranial nerves 2, 3, 4, and 6. So you can get diplopia and blurred vision and papilla edema. These are characteristic findings of meningitis. How do I know if it's leukemic related? You would need to do an LP. So I'd actually have to do an LP, test the cerebrospinal fluid, and look for that LP to show me cytology of the leukemic cells. So another thing I would need here is I would actually have to do an LP. So I'd actually have to take and do a lumbar puncture, because again, the meninges, you have that subarachnoid space, right? You would be trying to tap into that and take some of that cerebrospinal fluid off. And that would show me what? It would show leukemic cells. So it would show me lymphoblasts. And that presence of lymphoblasts with the findings of this would be enough for me to say, okay, this patient can have meningeal leukemia. We never want this. We never want this. So you know what we do whenever a patient has ALL? This is what happened to this young patient. She had to get intrathecal chemotherapy. So she was diagnosed with ALL, but we have to prevent the leukemic cells from spreading to the meninges. And so we'll put in Ommaya reservoirs, or we'll do lumbar punctures and squirt in the chemotherapy to prevent those leukemic cells from infiltrating that. That's why it's really important to remember this. All right? Okay, the last complication. Now, I want to preface, tumor lysis syndrome can occur in both ALL and it can occur in both AML, but we see it more common. So here, I want to write this down. You can see this, it's more common in ALL, but you can see it in AML. The concept behind this is that, again, your bone marrow is pumping out the lymphoblasts. When you have these lymphoblasts, right, and what we find is that in patients who have ALL, they tend to have what's called hyperleukocytosis, like crazy high levels of white cell counts. So they can have very, very high leukocytosis. We call it hyperleukocytosis. All right. Problem with that is that creates a tumor burden. Imagine I have 450,000 white blood cells. Could you imagine? That's a high tumor burden where if these cells, for some reason, decided to die, in other words, I trigger the initiation of chemotherapy. What is chemotherapy supposed to do? It's supposed to kill these cells. So that's what I want to do, is I want to stimulate these cells to die. But when I do that, they pop open and release all their super important contents, like phosphate, like potassium, like uric acid. And we see the presentation of tumor lysis syndrome. That's why when a patient has ALL and we start chemotherapy, we need to monitor for this and prevent this from happening. So hyperkalemia, what we know about this from cardio, from renal, is that this has a very profound effect on the cardiac system, particularly the electrical activity. And so what we may see is we may see arrhythmias, or we can see the classic ECG changes. And this is what they like to test on for the exam. What's your ECG changes that I need you guys to remember? Let's highlight them. What's the first presentation? You always remember, go up, this way, down, and back. So up is your peak T wave. Second is you go back, the prolonged PR interval. Down, you flatten the P wave. Back to the right, you widen your QRS complex. From here, if this progresses, it can become a sine wave and break down into VFib or asystole. Can you imagine how dangerous that is? So when we have a patient who gets chemotherapy, they have ALL, we like to put them on telemetry, where we constantly monitor them for any ECG changes or arrhythmias. What kind of arrhythmias can they develop? I just told you. They can have bradycardia, so they get bradycardia, or they could have cardiac arrest. So they can go into cardiac arrest. This could be asystole or VFib, or they could also develop bradycardia, particularly AV blocks. So they can develop like a first degree, second degree, third degree AV block. So this is important things to remember. So we gotta watch out for this. Now, hyperuricemia is where it kind of gets scary. So whenever you got lots of uric acid, right? This, let's represent it with this blue dot here, this little blue, this is your uric acid. When these little guys get over here, and they move across the glomerulus, what we see is that these little sons of guns are super toxic. They're nephrotoxic. They get into these cells here, and they can induce a nasty toxicity, and they cause damage to the proximal tubular cells. So now, I'm gonna have, what is this called? Acute tubular necrosis. So I'm gonna have acute tubular necrosis. I just stimulated that by these toxic uric acid crystals. Now, what happens is when these cells die, what do they do? Do you guys remember? They start sloughing off. So let's imagine here, I start breaking up this cell. And what I'm gonna do is, I'm gonna start shedding off, sloughing off some of that tissue. As I slough off the tissue, such an interesting word, slough. As I slough off that tissue, what do? I obstruct the flow of urine. Can you filter things across if all the pressure is built up in that tubes and in the capsule? No, you can't filter this. Look at this. All this is gonna be inhibited. Your GFR is gonna go down faster than you can ever imagine. And because of that, what's gonna happen is this is called an obstructive uropathy. So what is this called? This is gonna cause obstructive uropathy. So obstructive uropathy due to those nasty cells, and that's going to again cause a drop off in the GFR, an abrupt one. All right, because you're going to build up the pressure. You're going to build up the pressure in the capsule, and that's going to impede the net filtration pressure. Now, GFR determines the way that we clear metabolic waste. My GFR is going down. Am I going to clear metabolic waste? So if I'm impeding this process where things are supposed to be filtered or secreted, now this process is impeded. So I can't filter and I can't secrete because these cells are damaged. Bro, that's terrifying because now my creatinine can go up. And that's really what determines the incidence of an AKI. That's really whenever it goes up acutely, that determines what an AKI is. I can also see the potassium, the water, the protons, and the urea go up. So what if my potassium goes up? That's hyperkalemia, bro. Wait a second, Zach. They're already at risk for hyperkalemia. Exactly. That's why this is such a disaster whenever you have these two together. The other thing is that the water can go up. So they can develop hypervolemia. They can get volume overloaded. And then they can also build up their protons. They can get acidotic. And then lastly, if the urea builds up, it can cause uremia. And these are the concerns, right? So I'm not going to write those out, but again, hyperkalemia, hypervolemia, acidosis, uremia. It's really important to remember that. That's the presentation of an acute kidney injury. So an ATN is the way that these patients will present with what we would define as an AKI, an acute kidney injury. This is why this part is super critical to identify. The last thing is, so if a patient comes in, they got kidney injury, they got hyperkalemia, and they got a history of ALL, some chemotherapy, and then another thing, you check their phos levels. Phos levels are through the roof. You know what the problem with phosphorus is? You don't really think about it doing very much. One thing it does do is it binds free calcium. So it loves to bind that free calcium. If you got a lot of this, son of the gun, and it binds up the free calcium, what's going to happen to your calcium levels? It's going to go down. I have less ionized calcium, bro. Ionized calcium is important because High calcium blocks sodium channels. Low calcium doesn't block the sodium channels. These things are going to fire like a son of a gun. These neurons are going to go absolute ham bone, and they're going to fire and fire and fire. What's that going to present as? Neuromuscular irritability. What's that called? Tetany. I could come in with Chauvet's sign, Trousseau's sign. What else? Perioral paresthesias, seizures. It's pretty terrifying. The whole point of really identifying tumor lysis syndrome is that whenever a patient has this and they're getting treated, you monitor these things. And there's a mnemonic. I don't know if it's great, you may hate it, you may love it. I think it at least gives me a basic idea of the contributing factors. I like to remember puke, all in caps, and then calcium in lowercase. That phosphorus is elevated, uric acid is elevated, potassium is elevated, so these two, elevated calcium is lowercase, it's decreased. May help you a little bit to at least remember that these are the four characters that are the problematic issue in tumor lysis syndrome. Okay, now that we've done that, let's see what's the big presentation for AML. All right, so now we move on to the complications of acute myeloid leukemia. Now, it's really important to remember that for acute myeloid leukemia, can you get tumor lysis syndrome? Absolutely, you definitely can. All right, so in acute myeloid leukemia, they can get tumor lysis syndrome. All I wanted to emphasize is that you see it more commonly for ALL. The reason why I'm doing that is so that they present it in the boards, they're going to utilize that concept that it is more common in ALL. All right, so don't forget that. With that being said, we're going to talk about leukostasis and DIC because that's the two big complications that you see in acute myeloid leukemia. Can you see leukostasis in ALL? You can. You definitely can. It's just it's more common in AML. Let's talk about these. So leukostasis, what is this? This is basically a concept here where you see it in AML. They pump out lots of these myeloblasts, right? So you're going to get lots of these myeloblasts. Now, remember I told you that these account for white blood cells. So when you get a CBC and you get a white count that's like, 300,000, these are accounting for that. So the more myeloblasts you have, the higher that white cell count is going to be. The higher the white cell count, the more incidence of leukostasis you're going to have. At what point in the bloodstream, when you do a CBC, when these guys get into the bloodstream, at what point are you concerned about leukostasis? We get concerned about leukostasis whenever the white blood cell count is greater than 100,000. At that point, we start saying that, okay, there's so many myeloblasts here in the bloodstream that what it could actually do is it could do a couple things. One is it could increase the viscosity of the blood. So you're going to increase blood viscosity, and then that's going to start causing little occlusions. These like little white cells, they can start kind of like shoop, 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 and they get stuck in all of these like microvasculature. And so then what's going to happen is you're going to get microvascular occlusions. So now look at this. If I get these white cells, and I have so many of them, that they flow through here and they start kind of accumulating here and they get stuck in these like smaller microvessels. Blood, which carries oxygen, is supposed to be moving through this to these tissues. Am I going to be delivering oxygen to these tissues now? No. As a result, there's going to lead to decreased O2 delivery. That decrease in O2 delivery because of these white cells plugging up the microvasculature can then present with organ ischemia. And the reason why is if I start stimulating organ ischemia, this can present in different organ systems. For example, let's pretend these tiny little white cells get stuck here in the microvasculature of the MCA, or in the microvasculature of the ACA, or in the microvasculature of the PCA, or the microvasculature of the vertebrae. You get the point. They're clogging up these areas, decreasing oxygen delivery. It could be to the point where it causes mild symptoms, sometimes headache, dizziness, right? But the scariest fact is if it causes enough blood flow to be reduced to the brain where they start having neurological deficits. But it's only transient, they go back to their normal status. What's that called? A TIA. So in mild cases, it could be just a headache and dizziness. That could be the most mild scenario, but it could get worse, right? It could then progress to a TIA where you have transient ischemic attack, or it could go all the way to the point where you develop a true infarct of the brain. Here's an infarct, right? That's the scary concept here. So I could actually infarct this tissue if I'm not giving enough oxygen supply. It could start off where it's just headaches, right? That could be the first symptom. Then it could then progress to a TIA. Worst case scenario, it can progress to a CVA. So this is usually in the order of how it may progress. Sometimes they may go straight to a stroke. It might just be too bad. So that's one thing. The second thing that I need you guys to think about is it could also kind of plug up the flow out of the retinal veins. So imagine I occlude the retinal veins. Well, retinal veins are supposed to bring blood out of the retina here. But now that's going to be impeded because I got this occlusions here. If I occlude that, all this blood proximal is going to start building up. These retinal veins are going to get big as the son of a gun. Look at these fucking things, look at this. These things are getting huge. That's going to cause dilated retinal veins. If you get dilated retinal veins, the problem with that is that you cause a back pressure in the retina. And that back pressure, the issue with that is that it can cause hemorrhages to form within the retina. So sometimes this may cause what? It may cause retinal hemorrhages. Now, another thing that's really important to remember is that you have the optic disc. That's where like your retinal artery, the retinal vein kind of are through that area, and you even have the optic nerve. Sometimes when these retinal veins get super engorged and dilated, they cause the enlargement of that optic disc. And that's called papilledema. When you have this, when you have papilledema, that's one thing. That may cause the blurred vision. Retinal hemorrhages could cause blurred vision. These are the big things to remember. So oftentimes with this type of presentation, one of the big ways that these patients may present is they may present with that blurred vision. So this could be the fundoscopic findings, but this could be the symptomatology of those fundoscopic findings. So watch out for that. Could they be presenting here with blurred vision? That's the big thing to remember. The other one here is that sometimes these little white cells can plug up the pulmonary arteries. Could be in like the more distal ones, but it could plug up these pulmonary arteries. What are these supposed to do? Well, blood's supposed to go from the right atrium to the right ventricle, to the pulmonary arteries, to the pulmonary capillaries, where we deliver oxygen. Where we actually pick up oxygen at the alveoli, drop off CO2. Now, because of that, you're going to get a decrease in the gas exchange at the alveoli. So you're going to get a decrease in the alveolar gas exchange. If you don't exchange those gases, you're not going to be able to have a good oxygen. So you're going to end up with what's called hypoxia. That may be evident on the patient's SpO2. Or they may come in with dyspnea because of the hypoxia. They may come in with an increased respiratory rate to compensate for their hypoxia. They may be working hard to breathe to compensate for their hypoxia. These are the things that you want to be looking for. So because they can get microvascular occlusions in their pulmonary circulation, they can present with hypoxic respiratory failure or dyspnea due to their hypoxia. They can present with neurological deficits in worst case scenarios, and they can present with blurred vision due to the fundoscopic findings. All right? Man, that's leukostasis, right? And again, leukostasis is a pretty severe one. Now here's what's interesting. So you're probably asking, okay, Zach, I feel like you said back there that ALL can have hyperleukocytosis. So wouldn't ALL lead to leukostasis more likely than AML since their white counts tend to be higher? You would think that. But what we found is that there may be other alternative reasons, and this is what's interesting, as to why AML develops leukostasis more than ALL. It may not just be the elevated white count alone. It may be something else present that we just don't know yet. But for now, white counts greater than 1,000 with symptomatology is leukostasis. Which one do you see it more commonly in? It's gonna be more common in AML. But you can see it in ALL. All right, cool. Next one, DIC. This one you're only gonna see in AML. But again, it's specific. It's only in a subtype. Remember, mediastinal masses are only found in TALL? Well, in DIC, you're only gonna see that in APL, which is the M3 variant of AML. So it's only gonna be in APL. Now, if you remember, with APL, the bone marrow is going to be pumping out a lot of these. It's not the blasts. What was the big difference? You had that fusion gene, the PML promyelocyte retinoic acid receptor alpha gene. That was in the promyelocytes. So these are going to be your promyelocytes. They're like one stage after the blast. So you're going to have a ton of these little sons of guns. Now, promyelocytes are dangerous, and the reason why is they secrete lots of chemicals that these blasts don't usually secrete. And so when they get into the bloodstream, when they infiltrate into the bloodstream, these are disastrous, dude. So for example, they can release things like tissue factors. So remember tissue factor, that's something that activates the extrinsic pathway because it binds with factor 7. It can also release all these different types of coagulation factor activators. So it can activate other coagulation proteins. So the whole point here is that you're releasing certain things that are going to do what? Trigger the coagulation cascade. So I'm going to increase the clotting proteins. I'm going to increase my clotting cascade with this concept here. So these little promyelocytes are sons of guns. They release tissue factor, they release these activators of the coagulation cascade, and that pumps up my clotting cascade activity. Now, if I have clotting proteins, what do I need in order to bind to the actual vessel first to start a clot? I need platelets. So I need platelets present to be able to help that process. So what happens is the platelets will start sticking to the endothelium. When the platelets stick to the endothelium, that activates other coagulation factors. And these coagulation factors will then start, again, triggering that fibrin mesh to form. So platelets start the primary hemostatic plug, and the coagulation cascade leads to the secondary hemostatic plug. But either way, the combination of these two are what I get to form these microthrombi. So now what ends up happening is, in DIC, I get widespread microthrombi. These widespread microthrombi can lead to organ ischemia, but here's the problem. Here's where it really gets bad. When you use these clotting proteins, and I'm talking, you make a lot of these things, dude. You make clots all over the place. You consume your clotting proteins. You consume your platelets. So what ends up happening here is you end up with two effects. Because of the consumption of platelets and the consumption of clotting proteins to make all these thrombi, what ends up happening? So I increase the consumption of platelets, I increase the consumption of my clotting proteins. What does this do? The problem with this is I have these microthrombi, but now if I have a little nick in my vessel here, I won't have the platelets or the clotting proteins to stop the bleeding. So now, as a result, these patients can have clots and they bleed. That seems paradoxical, Zach, but that's what happens here. So they can get bleeding. This could be in the form of what? Ecchymosis, GI bleeds, brain bleeds. This could be prolonged bleeding after surgical procedures, oozing from IV sites. The list goes on and on and on. But this is usually bleeding that's going to be presenting because of the consumption of platelets and the consumption of clotting proteins. So if I have a new nick, I can't stop that. All right, that's interesting. So a patient can have thrombi and they can bleed. That is kind of interesting, but here's what gets worse. The promyelocytes, not only do they release these things to cause the clotting cascade, which eventually gets consumed, that causes bleeding, but they also release something called, so here's my promyelocyte. They release something called annexin 2. Now, don't go too crazy. All I want you to know is that it basically increases the activity. It leads to increased activity of plasmin eventually. Now, plasmin, if you guys remember, helps to break down fibrin and fibrinogen. And so what it's going to do is it's actually going to break down some of the clots. And so it's going to lead to the breakdown of fibrin and fibrinogen. This starts breaking up clots. Dude, what's that going to do? That's going to further worsen the bleeding. Oh my gosh. So not only do I have thrombi that are forming because of the consumption of the platelets and the clotting proteins, but I end up consuming them. I have less of them to stop myself from bleeding. And then on top of that, these dang promyelocytes, they release things that break down clots. So what do I end up doing? And even more? Again, I trigger more bleeding. That's why this disease is super, super, super scary. And it's something that you have to be able to recognize. Now, the next concept here, okay, we have patients that bleed and they have clots. But here's another thing. When you make these microthrombi, right, you know who just unfortunately get the brunt of this sometimes? Here's all these microthrombi. Red cells are just a little bit too big. So when they run through these microthrombi, they get shredded to pieces. It's terrible. And when they get shredded to pieces, they make these like weird shredded up cells. And what are these called? These are called schistocytes. So these patients will have schistocytes, and the only way that you can truly see schistocytes is you look on a peripheral blood smear if the patient has anemia. So they can get anemia and they can have the presence of schistocytes. So one of the ways that we truly diagnose a patient having DIC is those first start with bleeding. Skin bleeding, ecchymosis, or petechiae, or they can have prolonged bleeding from surgical sites. They have GI bleeds. They have brain bleeds. They have oozing from IV sites, all these different things. Either way, they're bleeding. And on top of that, we get certain types of labs. First thing I do is I get a CBC and I show that my platelets are low. So what would I see on my labs? My labs are the key thing here that helps me to make the diagnosis. So yes, it's not just the bleeding, but there's certain labs. One thing is I'm going to, because of the consumption, I'm going to have less platelets, right? So my platelets will be low. I'm going to rip up my red cells, so my red cells are going to be low. So I'll have a lower hemoglobin, right? If I look at the peripheral blood smear, I'll have schistocytes on the peripheral blood smear. If I look at, because I've consumed my clotting proteins, I can't now stop myself from bleeding. What happens to my coagulation labs, my PT, my PTT? Those all go up. So I have an increased PT and PTT. Because I'm making clots all over the place, what's one of the things that tells me if I have a heavy clot burden? D-dimer. So D-dimers will be elevated. And because I have consumed so much of my fibrin and fibrinogen, because I'm breaking down the clots, what happens to my fibrinogen level? That goes down. Do you see why I break this down? That precipitates bleeding, but it also lowers your fibrinogen. So then you have a low fibrinogen. These are pretty much characteristic for DIC. Okay, my friends, at this point we've talked about acute leukemias with respect to the patho, the causes, the classic findings, the complications. Let us move on to the diagnostic approach. Putting all of this together is really the key, right? Because we've talked about a lot. So if I see a patient who comes in with potentially fatigue and pallor, I want to think about anemia. If I see easy bruising and bleeding, I want to think about thrombocytopenia. And I hear that, oh, they've had a couple infections this year and they've had frequent fevers. I want to think about neutropenia. These things are telling me the sign of pancytopenia. And I can get a little bit more specific. And if they say anything about bone pain or having difficulty bearing weight or limping, I think ALL. And if I hear mucocutaneous lesions on their manifestations of their physical exam, I'm thinking AML. So, okay, I want to prove the pancytopenia and I want to look at the specific type of cell in the blood and the bone. So I get a CBC, make sure it's with a differential so I can tell the types of white blood cells, and then I get a peripheral blood smear to get an idea of what's the actual cell in the blood and see if it can help me determine if it's lymphoblast or myeloblast. So if I do the CBC with diff and I see that they got pancytopenia, all those cell lines are low, that would support these symptoms. And if I see they have lots of blasts on their differential, oh, okay, cool. That tells me that these are definitely more of the acute types of features. This could be an acute leukemia. I have to look at the actual blood smear and say, is it lymphoblast or myeloblast? So if I look and I see lymphoblast, that's very helpful. And when you kind of look at a blood smear here, you can kind of see I have a lot of red blood cells here. When I zoom in, look at all these are tons and tons and tons of lymphoblasts. And when you really zoom in here, you can kind of notice, oh yeah, wow, these are very large appearing cells with a very large nucleus and large cytoplasm. This is characteristic of my lymphoblasts. Now, it doesn't guarantee that the patient has ALL. The reason why is this is just in the peripheral blood. I actually have to confirm that this is in the bone marrow. So I would have to follow up and get a bone marrow biopsy. But let's say that I move to the next step, which is, all right, I have another patient who has a differential that shows pancytopenia. They get increased blasts. Maybe they have mucocutaneous lesions. And when I look at their blood smear, I see myeloblasts with our rods. And so when I zoom in on this portion here, I see, oh, wow, this is definitely a really huge nucleus. Oh, what's that? that, that's our odds. Our odds, oh, that was always associated with acute myeloid leukemia. Again, not a guarantee, but it's very, very likely. The only way that I can prove all of this is I got to get a bone marrow biopsy and send that sample off. Look for those CD proteins, look for the TDT, look for the MPO, and really figure out, is this a lymphoblast or is it a myeloblast that's in the bone marrow causing all of these problems? So if I see greater than or equal to 20% lymphoblast on the biopsy, boom, it's ALL. I got it. If I got greater than or equal to 20% myeloblast on the biopsy, boom, it's AML. But then the question is with ALL, is it T or B? That's where the flow cytometry and immunohistochemistry comes in. If I do that and I see CD10, 19, 20, and TDT, oh, dude, that's the B lymphoblast. And if I see, oh, it's TDT, but CD2 to 8, oh, that's the T lymphoblast, right? And then, what we can actually say is I can get cytogenetic studies, which really look at the types of mutations or chromosomal translocations. And remember, there was two, 1221 and 922. If I got 1221, that's for pediatrics, it is good prognosis. And if I get the 922, the Philadelphia chromosome, that's in adults, that's bad prognosis. So that's also something that we can do from this study because it helps to guide kind of our treatment progression. Now with AML, there was like 8 subtypes. Again, you can actually look at these on the biopsy and kind of get an idea. If you really wanted to know specifically though, from those, which type, again, you could do the CD13 and 33, but the MPO is the really big one. If you see myeloperoxidase that's actually present on their flow cytometry or their immunohistochemistry from a myeloblast from their bone marrow biopsy, it's AML. What you could then do is take it a step further and get the cytogenetics. Why? Because I want to look for one specific chromosomal translocation. Remember? 1517. If I find the 1517, what was that associated with? Come on, spit it out. APL. All right, that was the PML RAR alpha gene. All right, fusion gene. All right, now what if I have a patient coming in with complications, like some scary ones that we talked about? We talked about a lot of them. Let's put it together. So if they come in with these oncologic emergencies per se, so I see stroke symptoms. So they have maybe there's some dizziness, some TIA, they have some focal deficits, they have shortness of breath, they have hypoxia, and I get a white cell count and it's greater than 100,000. They have hyperleukocytosis and organ ischemia symptoms. That's leukostasis. If I hear meningitis symptoms, headache, nausea, vomiting, nuchal rigidity, some cranial nerve palsies, what am I thinking? I'm thinking meningitis, but I'd have to prove that by getting an LP to see the leukemic cells. If I hear face, neck, arm swelling, and in worst case scenario, their intracranial pressure is high, so they're having neurological deficits, or they're having respiratory distress from laryngeal edema, I'm thinking SVC syndrome, right? Especially the T cell ALL. And if I hear coagulopathic bleeding, so I hear that they're having a lot of hemarthrosis, ecchymosis, bleeding from IV sites or from catheters, they're having a lot of these problems, I'm thinking DIC, especially with APL. And if I hear that their creatinine bumped up significantly, they're having arrhythmias that are showing peak T waves and prolonged PR intervals and dropping of their P waves and widening QRS complexes, I'm thinking about the hyperkalemia factor. And if I hear that gout flare and the AKI, I'm thinking about that uric acid that's causing a lot of these diseases. Especially, we see this in ALL. This one, AML, ALL, T cell ALL, and APL. Now, we can really thoroughly evaluate all of this, and this is kind of an initial stuff. You can get coagulation studies, and you can extend that out. We can get a PT, PTT, we can get an INR, we can look at fibrinogen, we can look at a D-dimer. All this is trying to do is prove this. Uric acid, I'm trying to prove if there is potentially, especially with a combination with a CMP, if their uric acid's high, their potassium is high, their phosphorus is high, calcium is low, I'm looking for tumor lysis syndrome. CT chest with IV contrast, I'm trying to see if the SVC is compressed. I'm looking for SVC syndrome. And a lumbar puncture is looking to see if there's leukemic cells that support meningeal leukemia. So again, a lot of this is really putting it together. So technically, leukostasis is a clinical diagnosis. You need a white cell count, a greater than 100,000, hyperleukocytosis, and ischemic symptoms. That's the diagnosis then. If I hear that a patient is having some meningitis symptoms, I get a lumbar puncture, comes back negative for really any kind of disease like bacteria or viruses or fungal. But when I throw off cytology from tapping in there and it comes back positive for leukemic cells, it's meningeal leukemia. If I get that CT with IV contrast coming through here the chest and I say, oh my gosh, there's a big goober here, and it seems to be, oh, that's the SVC, look at it, it's tiny as can possibly be. That's probably my superior vena cava syndrome. And if I have a patient who's bleeding and then I look and I get their PT and their PTT and it's elevated, they got a low fibrinogen, a high D-dimer, and add on that other thing, they have thrombocytopenia, they got schistocytes on their blood smear, that's really supporting that DIC picture, all right? And then lastly, if I hear a patient has, arrhythmias, they're having high potassium on their CMP, high uric acid when I test that, their phosphorus is high, their calcium is low, and they maybe got a recent dose of chemotherapy, I'm thinking about tumor lysis syndrome. All right. So this is really a very comprehensive approach in that sense. But before we treat the disease, we should treat some of these acute complications. And we talk about this in a lot of different systems, but it's always good to have overlap because you'll remember it when it's actually necessary. So in tumor lysis syndrome, the problem here is that you get a lot of these crystals, the uric acid crystals, and they can really cause a lot of damage. And sometimes there's not a lot of evidence, but you can try and really fill their vascular system to flush some of this uric acid out and prevent the actual precipitation of them, which can worsen kidney injury. So it's always good to maintain good IV fluid resuscitation, just to avoid volume overload. The problem with tumor lysis syndrome is the uric acid. We want to try to lower that as much as possible, because if you go back to your kind of biochemistry, whenever these cells pop open, they release purine nucleotides that can convert into hypoxanthine, into xanthine, and then to uric acid. Uric acid is the problem. This is the one that kills the kidneys and causes that nephrotoxicity, right? So we have enzymes that help in these processes. Xanthine oxidase helps to make this step, and it also helps in this step. Well, if I had a drug theoretically that could inhibit xanthine oxidase, like allopurinol, what I may be able to do is reduce the uric acid because it's going to inhibit these steps. And so I'll end up with like less uric acid potentially, right? And that's less nephrotoxicity. Problem is that it's only going to inhibit what kind of like in a degree, it's inhibiting uric acid formation. In a patient who has tumor lysis syndrome and they already have uric acid out there, it just prevents further uric acid, but it doesn't actually reduce that already present uric acid. And so that's why it's really only good at decreasing uric acid before it's formed. That's why it's more of a prophylactic therapy. Whereas rasburicase, this is actually better in an acute scenario, because what rasburicase does is, let's say that uric acid's really high, and I give them a drug that actually can convert uric acid into a very less toxic form that can be easily excreted from the kidneys. There's no nephrotoxic effect. That would be great because I convert a lot of that deadly stuff into the less toxic stuff. That's where rasburicase comes into play. It actually helps to convert uric acid into allantoin, which can be excreted very nicely, and it doesn't cause any nephrotoxicity. That's the benefit of rasburicase. So we use this in an acute event, and this is more of a prophylactic event. But IV fluids should be given no matter what if we're concerned about this. All right. Now, with leukostasis, the problem is we got tons and tons of white blood cells. We got to lower them. So acutely, what you'll probably be doing is 2 therapies up front. That's at least what UpToDate supports, which is hitting them with hydroxyurea. It's a cytoreduction agent. So it hits the bone marrow and shuts down the production of mostly a bunch of different cell lines, red cells, platelets, and white cells. Problem is it kind of takes a little bit of time, so it's good as more of a chronic and preventative or prophylactic effect. But when you need to rapidly remove white cells, this is really the thing that you want to do is add on leukapheresis. So leukapheresis, basically, you're going to remove the blood from the patient, right, which has all of these heavy amounts of the blasts. In this case, since we're talking about leukostasis, we're talking about AML. All right, so we want to remove a lot of those, and then what we want to do is we want to centrifuge it to separate it onto layers, and then we're going to get our red cell layer, our buffy coat layer, which contains the platelets and the white cells, and then you're going to get your plasma. All I want to do is get rid of those white cells, all of those excess myeloblasts. And as I do that, I can give back the blood to the patient that I have, I don't have any need to actually remove, like their plasma and their red cells and their platelets. So that's the goal of leukapheresis, is to rapidly reduce it. So we do that a lot when they're severely symptomatic. All right. Now, DIC, a lot of it's really just supportive. If a patient has a low platelets and they're bleeding, you give them a platelet transfusion. If they have a low hemoglobin, and they have, again, potentially in this scenario, we wait for at least less than 7, we'll transfusion with a packed red cell. If they have bleeding and they have an increased PT and PTT, you can give them FFP. The thing about DIC with acute leukemias, especially APLs, we actually do have a specific treatment, and it's called all-trans retinoic acid, oftentimes abbreviated ATRA. And the cool thing about this drug is, if you guys remember, the 1517 translocation makes the fusion oncoprotein, the fusion oncogene, which makes the fusion oncoprotein. And this put the differentiation block on those promyelocytes and said, you can't convert into a neutrophil or an eosinophil or a basophil. And so that was the problem. So you build these things up. What if I had a drug like all-trans retinoic acid, which basically what it does is it takes and actually adds ubiquitin onto this fusion oncoprotein. When you ubiquitinate something, oftentimes it tells proteasomes, which are things that break down proteins, to say, oh, I see something, let me eat it. And it goes through and it rips that thing apart. Now you don't have any of the PML or R alpha. If I don't have this, is it going to be able to put a differentiation block anymore? No, guess what? These things differentiate. And when it differentiates, it actually can, funny enough, if you give this, sometimes it can cause differentiation syndrome where you make too many of these neutrophils, but that's neither here nor there. It can make a lot of these neutrophils, which converts them. And so now you have less risk of a lot of the problems that comes with APL, like DIC. And so that's one of the benefits of this drug. Intrathecal chemotherapy with methotrexate is really the stand-hold therapy as prophylaxis in patients with the diagnosis of ALL. We can access their cerebrospinal fluid, which can have contact with the meninges as it flows across it via an Ommaya reservoir. So we can take and we inject the medication into this, right into their cerebrospinal fluid, right into a ventricle. Or we can access their cerebrospinal fluid via the lumbar puncture and inject that medication right in there as well. Again, it'll come into contact with the meninges and it'll get rid of a lot of those leukemic cells, or at least prevent them in a way from forming there. So we oftentimes do this as prophylactic to prevent that with the diagnosis itself. But if the patient actually has infection, which is confirmed via LP, or not infection, but the infiltration of leukemic cells, we have to give pretty high doses and a little bit longer than desired. All right, SVC syndrome, really a lot of the times it comes with treating the underlying disorder. So if you have a tumor in that area, sometimes you may have to just do chemotherapy and some radiation therapy and some steroids. Usually the radiation and the steroids are the big thing up front, but that's going to be in a patient who doesn't have severe emergent symptoms, because steroids are going to take some time and so are the radiation therapy. If a patient has high ICP or laryngeal edema with respiratory distress, we ain't got time to do that. We got to put a stent in and keep that thing patent so we can get blood flowing in. So oftentimes we'll put a stent in to just keep it open, and then we'll hit them with that chemo, radiation, steroids to kind of debulk the tumor and decrease it in size so we have less compression. You're treating the underlying disorder that way. So that's a lot. So how do we kind of put it all together? Well, if I said that I got a patient who comes in with leukostasis, what do you do up front? Well, leukostasis, I'll do hydroxyurea first, right? Especially if that white count's really high. It may take some time. So what do I want to add on, especially if they're really symptomatic? I want to add on leukapheresis because it's going to rapidly drop that white count, reduce the further disease. If I hear meningeal leukemia, prophylactically with the diagnosis of ALL, I do intrathecal chemotherapy, right? But if they end up with a diagnosis from an LP and they have meningeal leukemia symptoms, I got to do high doses. If I hear SVC syndrome, I just want to know, is it an emergency with high ICP, laryngeal edema, hypotension? If it is, stent. If it's not, then what do? I say, okay, I'm just going to go ahead and get them ready, schedule them with radiation oncology, get some chemotherapy, but particularly radiation therapy and steroids along with chemo, shrink the tumor, and that should help with that process. All right. If I hear that the patient has DIC, I'm going to support them the best I can. If they have platelets that are less than 50,000 and they're bleeding, I'm going to give them a platelet transfusion. If they have hemoglobin less than 7, I'm going to give them a packed red cell infusion. If they have high PTT, PT, and they're bleeding, I'll give them FFP. But again, a lot of it's supportive. But if they have APL, I have a specific treatment. That's all transretinoic acid. And then lastly, if a patient has tumor lysis syndrome, we want to know, is it acute? So do they have the puke calcium symptoms? If they do, IV fluids to really reduce a lot of further kidney injury, maintain good euvolemia. And what is the one that reduces uric acid after it's already formed? Rasburicase. All right. And then after that, you can again say, okay, the patient, I give them the rasburicase, but unfortunately they sustained so much damage to their kidneys, and they ended up with hyperkalemia. They ended up with worsening acidosis. They ended up with hypervolemia and uremic symptoms. What do? You dialyze them like you would any AKI patient that progresses that way. But if it's a prevention, this is not a patient who has acute tumor lysis syndrome, but they have a high a high risk or a probability of developing that. You do IV fluids to keep them euvolemic, but you give allopurinol to decrease the formation of the uric acid if it forms. Okay, so let's move into the actual treatment of the underlying disease. Treating leukemia involves obviously chemotherapy. And so when we talk about acute lymphoblastic leukemia, obviously it comes with its plethora of complications that we talked about managing, but we also have to consider the treatment of the actual underlying disease. And so when we think about this, we think about something called the CVAD regimen. And so this is really consisting of a couple different chemotherapeutic agents. One is going to be cyclophosphamide. The other one is vincristine. A is adriamycin, also sometimes referred to as doxorubicin, and dexamethasone, which is a type of corticosteroid. And so we're basically giving these to kind of reduce a lot of those leukemic cells in the bone marrow, especially if that patient does not have a 922. What's the most common for acute lymphoblastic leukemia, if it's a chromosomal translocation, it's 1221, right? So this is going to be the CVAD regimen for most of those patients. However, if the patient does happen to have cytogenetics that support the 922 translocation, we actually target the BCR-ABL, which actually targets your tyrosine kinase receptors. And so we're going to give them tyrosine kinase receptor inhibitors. And that is going to be things like imatinib per se. And any of your NIBs, those are going to be the ones that are going to be targeting that BCR-ABL fusion gene, all right? Particularly at the tyrosine kinase receptor point. Now, obviously with the goal of the disease is that you have a hemocytoblast or a myeloid stem cell or a lymphoid stem cell with acute leukemias that are not differentiating and they're just building up. And so what if we replaced a lot of our stem cells, our hemocytoblast or the actual lymphoid stem cells, with normal stem cells? And if we replace those normal stem cells, they won't have these genetic predispositions with the 1221, the 922, the trisomy 21, all of these mutations that they've encountered. You're giving them normal stem cells that can differentiate and proliferate into normal red cells, normal white cells, normal platelets, etc. All right, that would be the goal, but we only do this in patients who really have that high risk. They're basically on chemotherapy and they potentially are suitable for getting a bone marrow transplant. Now, with acute myeloid leukemia, it's really cytarabine and daunorubicin are going to be the drugs of choice that we will actually target to kill these leukemic cells. Now, all trans-retinoic acid is the really important one that I talked to you guys about in DIC. The reason why is you're giving them supportive treatment, but you're treating the underlying disease with all trans-retinoic acid. There's been a lot of literature that suggests using arsenic trioxide in combination. This is another drug that you can give. So again, the kind of question that you'll get on treatment of acute myeloid leukemia is probably going to be more pertaining to this one. All trans-retinoic acid is really, really helpful, but there is becoming more literature to support the combination of both of these, especially in those high-risk patients and with APL. Again, the concept behind this is that, again, you're trying to remember that with that 1517, you're getting that fusion gene, they're getting that fusion oncoprotein, and that puts the block on differentiation. If you give them these medications like ATRA, all trans-retinoic acid, it ubiquitinates this fusion oncoprotein, which kind of sets it up to get degraded by proteasomes. Arsenic trioxide can also help in that process. But if you get rid of the PMR alpha fusion protein, you basically say, hey, no more differentiation block. And now the cells are allowed to proliferate and differentiate, and you now have normal neutrophils. And that's the goal. Now, lastly, as with, again, any acute leukemia, replace the stem cell, because if I can replace that myeloid stem cell with a normal stem cell that doesn't have mutations or any kind of chemoradiation that damaged it, or myeloproliferative neoplasias or myelodysplastic syndrome that are present, I'm giving a normal stem cell that's capable of differentiating into our normal types of granulocytes. And that's the ultimate curative goal. Again, you're doing this in patients who you're treating with chemotherapy, and maybe they're not getting a little bit better. They're high risk of continuing to get worse if you don't kind of do something, if they have the proper candidacy and they're fit for a transplant. So my friends, that covers acute leukemia. I really hope that you guys liked it. I really hope that you enjoyed it and learned a lot. And man, I love you guys. I thank you guys. And as always, until next time.